It's a great pleasure to be here and an honor to be here. And I must thank the organizers and particularly Sudha Mayappan for having me here today. Now, Parkinson's disease and its psychological manifestations has been a very interesting topic of research and work for me. I've worked on it for the past few years. And today I'm just going to summarize some of the features, some of the issues that we may face in someone who is experiencing Parkinson's disease. And the purpose of this is to actually inform you of what is seen commonly and what can be done to help. Okay, thank you. Can I have the first slide, please? Okay, I had a picture which unfortunately hasn't come up, and it's like the freezing manifestation sometimes you see in Parkinson's. I think that's kind of unexpected things do tend to happen when you're dealing with someone with Parkinson's. That's kind of, it's very common. Now, I'll just present two case vignettes. I think Mrs. Agrawal presented her story and in a very poignant way, and it's not uncommon to hear similar stories from across a spectrum of people with Parkinson's disease. I'll just present two cases just to kind of set the scene. She already has here. Now, this is one of the first few patients that I encountered in my career as a psychiatrist when I was dealing with someone with Parkinson's disease. I was called in to see this gentleman in the hospital. He was admitted with a heart disease with an acute myocardial infarction. But post myocardial infarction, he started to become very agitated and restless. And he had a long history of Parkinson's. And the most distressing symptom was he saw his daughter's face, image of his daughter's face everywhere, on the walls, in fact, on my shirt, and everywhere around him. And it was being torn into pieces by people. And he kind of saw blood dripping all over the place. It was quite distressing experience for him. And he also heard voices, and he thought that people were coming to do something to him. And it was a very distressing symptom for him. Next slide, please. This is another lady who I saw quite recently, who is a homemaker and has been having Parkinson's for quite some time. In fact, she's a relatively young woman, and her main feature has been she sees police personnel in her house going through her things, and at times they wouldn't bother her, but many a time she would find that very distressing, and she would think that people are going to arrest her for something that she has done in the past, and that would become very distressing for her. And that was a big problem because she would attempt to leave the house, and anytime she heard the police siren on the road, then she would think that they were coming to pick her up. So that was quite distressing for her. These two examples are just to set the scene. Now, what is psychosis? Again, there are lots of definitions for psychosis. I just took the most common one and in Oxford Dictionary. And it kind of talks about a severe mental disorder in which thought and emotions are so impaired that the touch with reality is lost, the contact with reality is lost. And of course, this is a definition in the dictionary. And as a practical way of using this definition, I find it difficult. So I will define it this way. So it's a severe mental disorder, no doubt about that. But the thought and emotions may not be so impaired, they can be mildly impaired, and that causes problems. So they are impaired nonetheless, and the contact is not always lost with external reality. It is fluctuating, and it may not be completely lost. So people do retain a degree of insight into their problems to a large extent. So they may lose contact with external reality. Next slide, please. So what are the main symptoms of psychosis? We're going to talk about two, hallucinations and delusions. We'll kind of elaborate on that in a wee while. Next slide, please. So talking about hallucinations. What are hallucinations? Hallucinations are disorders of perception. Perception is anything to do with our sense organs. It can be to do with vision, with hearing, with taste, smell, or touch. So it can involve any of our sensory organs. And it is a sensory perception without any stimulus. Normally, when we see something, when I see all of you here, you're really here, or I would assume so. Now, for someone with a hallucination, they may see people who really aren't there, or experience voices when nobody is actually speaking to them. So that's the difference between a normal perception and an abnormal perception. Now, this is a disorder of perception wherein multiple sensory organs may be affected or systems may be affected. And one of the most commonly affected system is the visual system. Next slide, please. The main symptoms when we see people with Parkinson's are looking at the first common presentations. The early symptoms are usually false sense of presence. They may say that somebody is around me, somebody is behind me, I can sense somebody behind me. I mean, that will be a very common symptom, and many a time it may not be that serious and it's not persistent. In fact, they don't lose touch with reality. They do know that it's not true and it is something which is happening to them, maybe frightening, but sometimes they just accept. They think there is somebody behind me. Okay. The next is passage hallucinations, where they think something is passing them just on the corner of their vision. They see something flitting by. They see it's an animal running past them, or a small child crawling, or somebody just hiding under the bed, or somebody hiding behind the cupboard. They turn and there's nobody there. And that's again a very common experience in people with Parkinson's disease. Now, as the condition progresses, or sometimes this can be quite severe, where we can see a well-formed hallucination. And it can be in terms of people, objects, animals, or patterns that they kind of start seeing in front of them. And they can be either they will not be bothered by these experiences. They think there is somebody there and it's a social visit. And sometimes they even have a conversation, they try to have a conversation with these people. But at other times, it may be very distressing for them. They will become very distressed by these experiences, like the two case examples that I mentioned earlier on. So the experience is so distressing that they are restless, agitated, they become angry, and sometimes they become very depressed. These are the common hallucinatory experiences that people with Parkinson's disease may have in their visual field. Next slide, please. Now, there may also be disturbances in other disorders or other systems of perception, particularly auditory hallucinations, and they may be present in many patients, but they're not a common presentation. They may be associated with visual problems. Now, we will not dwell upon that a lot, just to assume that, just accept that they do present. Now, delusions are the other major category of problems or psychotic problems that we will see in people with Parkinson's disease. Now, delusions are disorders of belief. Now, the definition of delusion is a little bit tricky. I'm just going to use the most commonly used definition here. It's a belief that's maintained despite evidence to the contrary. Or someone trying to have a logical conversation with this person and say, this thing doesn't exist. Nobody's trying to harm you. Why would somebody want to harm you? You're loved by everyone. But the person will not accept that. They think there is a conspiracy going on behind and people are trying to harm them in some way. So they tend to have a belief which is quite unshakable to them, and we cannot prove that that belief is not true for them. For them, it's very true. Now, it can take various forms. The most common form is delusion of persecution, where they feel persecuted. They think somebody is after them, they're going to do something to them. The other common ones are delusions of jealousy, where they think their loved one, particularly their spouse, is having an affair with someone else, or somebody is visiting their wife or their husband at other times when they are not around or when they are sleeping, and that can be a major distressing belief for them. Delusions of guilt. They sometimes feel that they have done something bad and they're going to be punished for that, and it can take various forms. For example, that particular lady that I mentioned who believed that she was going to be arrested, she thought that she had done some mistake in the past and she is going to be punished for that purpose. And rarely we do see delusions of grandiosity, wherein they think they have extraordinary powers and they want to spend a lot of money and they have a lot of power. So that's kind of quite rare in Parkinson's disease, but I have seen a handful of patients with that problems. And so on and so forth. There are so many varieties of abnormal beliefs that people may start to experience. We will not be able to list them all here. It is just for you to understand that people may have a belief which to them is very true, but to you seem very illogical. Okay? We'll talk about how to deal with them later on. Next slide, please. So the question is, how common is psychosis in Parkinson's disease? Now, when you look at the history of Parkinson's disease, when it was first described by Parkinson, they kind of didn't the neuropsychiatric manifestations of Parkinson's disease wasn't given a lot of importance. Actually, there was a mention, but not to the extent they thought that it was a problem. Now, here, in fact, more recent studies have shown that, in fact, more than the first motor manifestations of Parkinson's disease, the neuropsychiatric symptoms can be quite a big problem and quite a big chunk. And they tend to coexist with the motor symptoms, often hidden away, often not talked about, often not dealt with. So it's like a hidden portion of a submerged iceberg. About 50 to 70% of people with Parkinson's disease at some point will have a psychotic symptom. Almost all of them will have a neuropsychiatric symptom, which can be in terms of depression, anxiety, or sleep behavior changes and disturbances, any of those manifestations. So it's extremely common, but psychosis tends to occur in more than half of people with Parkinson's disease at some point in their illness career. The next, no, I'll go back to the previous slide, please. Now, the next common experience are what we call as illusions. Now, we've dealt with the main core psychotic symptoms, hallucinations and delusions, but illusions are quite common. Now, illusions are what we say in common parlance. It's there, but you misperceive it as something else. Now, here, I don't know how many of you see people, I don't know how many of you see pillars. They're both there. So it's from how you kind of view it, and it can seem like that to you. Now, a common experience in people with Parkinson's disease, they misperceive things around them in their environment. Often they misperceive a shadow as somebody standing there, or a cloth hanging on a coat hanger or on hanger. They think there's somebody standing in front of them. Or they may see patterns on the floor as insects or animals or snakes sometimes. It's a common kind of problem that we see. Cracks on the floor are misinterpreted as snakes or insects or bugs. And in fact, when we have curtains when they are kind of flowing and in the wind, they may think that somebody behind them, and the patterns that appear on the curtains are misinterpreted as something being hidden in the curtain. Now that is a very common problem. It happens to many people, even people without Parkinson's disease, but the chances of it occurring are more in people with Parkinson's disease, and especially those with any degree of cognitive impairment. We'll come back to that later on. So illusions, as I just mentioned, they are misperceptions of real stimuli. Compare and contrast with hallucinations, where there is no stimulus. They think there is something there when there's nothing existing. In illusion, there is something there, but is misperceived as something else. Okay, that's the difference between an illusion and hallucination. We're present in about 60% of people with Parkinson's, and we kind of discussed the other point already. Next slide, please. Now, the question is, what are the risk factors for people experiencing these symptoms? So why do people experience these symptoms? Now, as I said, 50 to 60% or 70% of people with Parkinson's experience this. Not all of them do. So 30%, a significant proportion, do not have these symptoms. So what increases the risk of people experiencing these symptoms? The most important problem are the coexisting physical health problems. So we will come to that in a minute. But the physical health problem, because when we look at a person with Parkinson's, we just don't see Parkinson's disease alone. As the person is aging, they tend to develop multiple illnesses that comes along with aging, along with the process of getting older. The common ones being diabetes, high blood pressure, or they may have arthritis, they may have kidney problems, they may have thyroid problems. As we get older, we tend to develop various problems. Changes in their vision, so they may have cataract, they may develop macular degeneration. If they have diabetes or hypertension, they may have changes because of that in their eye. So all these things come together. And also, as we get older, our hearing ability comes down. They are not hearing things very well, and they think somebody is talking about them. Okay? So these kind of things add on to their experiences. So physical health problems are the most important risk factors for people developing symptoms of psychosis and Parkinson's. The next most important factor is environment. Now we'll talk about why these things are important, how we can actually manipulate these to give a better experience for someone with psychosis and Parkinson's disease later on. That's the reason why I'm kind of persisting on these kind of features right now. So environment is again a very important issue. We'll come to that. Social situation and respond to others. So what is happening in their personal life? What is happening in their social circumstances? Are they experiencing any stress? Are they experiencing any problems at this point in time? It could be issues with loss, bereavement, various other things which can happen to a person with Parkinson's disease in their life. And how people react to them when they talk about their experiences. So that also determines how the symptoms progress and how they manifest into the outside world. What are the associated? There may be other associated features which happen in people with Parkinson's, as I already mentioned, but the more common neuropsychiatric symptoms like depression, dementia, or sleep disturbances, they can actually make the experience of psychosis even worse. And in fact, people with these three conditions are at a higher risk of developing psychosis, and people with psychosis in Parkinson's are at a higher risk of developing dementia in Parkinson's disease later on. Next slide, please. So, talking about poor physical health issues and poor physical health. Now, I can't agree with you more when you said that keeping fit is so important for someone with Parkinson's disease. Now, physical health is, as I mentioned, the most important risk factor for developing psychotic symptoms. Poor vision, so we already discussed that. Impaired hearing, again, people misperceive stimuli, people tend to misunderstand what is being said to them, and that causes a lot of problems for them. Constipation, a common experience in people with Parkinson's disease, that by itself can cause or precipitate psychosis in someone with Parkinson's disease. Infections, common infections like urinary tract infections or chest infections can actually cause or precipitate a psychotic breakdown in somebody with Parkinson's disease. Dehydration, again, many people with Parkinson's, in fact, many older persons don't drink enough fluids. They don't keep themselves hydrated, and that causes, and they say that if I drink more, I need to go to the bathroom more. So they kind of stop drinking, and that actually complicates things further. That actually makes them more constipated. It causes changes in their blood electrolytes, and then it also affects how their brain overall functions. So it kind of is it's simple things, but can make a huge difference to someone's life. Pain. Many people with Parkinson's, in fact, it's a bugbear of mine, people with dementia in particular, and those with Parkinson's disease, they don't actually communicate that they are in pain. I have seen people who have had a fracture, left nothing being done for a couple of days, assuming everything is normal. They're just distressed, they fell, they're distressed, and that's just because they fell and nothing else is wrong. But actually they had a fracture, but they cannot tell you that they are in pain and they can't move their leg. So we need to actually carefully examine them to identify any physical health problems, and particularly pain. Next slide, please. The environment. Why environment is important? Maybe, yeah, we can kind of go to the next slide. I don't know if you can see that picture very clearly. This is actually a home of a patient of ours, and that's the approach to his room with cupboards on both sides with mirrors on them. And every time he passed through that corridor, it distressed him. It distressed him no end. And he would become very agitated and restless. He just saw his own reflection and he would become very agitated and restless. And again, this caused, he thought somebody was standing at the other end of the corridor. He would try to run, he will fall. So there were lots of problems with environment. And that's his library actually. That's his, how his library looked. So it causes a lot of problems for when the environment is not adequately maintained or it's not designed to help and support them. Next slide, please. So when you look at what practical things that can be done to improve the environment, lighting is probably the most important. Easy to fix, can be done, and can actually make a huge difference in someone's life. Adequate light, avoiding shadows, having a dim lit light in one corner of the room, the vast majority of the room being in shadow, doesn't help someone with Parkinson's disease. So in fact, it can actually cause psychotic symptoms in them. So providing adequate light, LED bulbs of very good luminosity actually make a huge difference. The LED lights generally don't throw shadows if you have a few of them on the room, and that actually makes a huge difference to their lives. So opening the windows during the daytime so that there's adequate natural sunlight into the room, keeping the windows clean, Again, many of the windows are dirty, and they see patterns on the windows, and they assume that something is there, or they see a shadow and they think somebody is peeping through the window into their room, and that causes problems for them. Reducing the glare in the room, and better lighting. We already talked about that. Next slide, please. Again, sound, common sense. So not too loud, and again, not in a quiet environment. Kind of having an adequate mixture of sound at appropriate times. I think that's the key thing there. So not too loud, not too quiet, but at kind of the right kind of level. Next slide, please. And again, hearing aids. If people are kind of forgetting to use their hearing aids, reminding them to put them on, to check if the batteries are working. All these things are common practical steps which can help. When you look at this, it's a floor mat right by a door, and the person living in that environment thought there was a big gaping hole by the door, so they would avoid, they step around that and they walk carefully. And again, misperceiving stimulus in their environment. So not very good. So the things that we need to do is, again, using light, plain curtains, not dark ones, not with patterns. Again, the most the easiest thing that can be changed is if you have a curtain which has a lot of patterns on it. Sometimes people have pictures of people or trees or creepers on their curtains. Actually, they just don't help. In fact, they make things worse. So keeping a plain, kind of light colored, plain curtains actually make a huge difference to someone when they're having these psychotic symptoms. So the floors need to be slip resistant. They shouldn't be reflecting. So any reflecting surface, when they kind of, either when there's a source of light or when the doors are open, they tend to see a reflection and they think there is something going on there. So again, that's very important to kind of work on. Next slide, please. Again, when someone is talking about their experiences, how do others react to them? That is extremely important. So when others are confrontational, when they're trying to say, I mean, as caregiving can be quite burdensome, as we've already heard, and can be quite difficult, and this person constantly talking about their, things which are not actually there, and people tend to lose their cool at times, and they become, quite loud, and they say, "Onnulla ukkar, chumma yen kathite irukka," kind of the comments which are not often helpful. So confrontational method of approaching this, or even dismissive kind of way of just dismissing the symptom as nothing is happening, can actually put people down, and they feel that they are not being respected, they are not being heard, and that actually complicates symptoms for them. So it's important that we kind of are quite supportive and validate their experience. Doesn't mean you have to agree with them. It doesn't mean that when they say there is people standing behind me to say, yeah, I see them, I want to, I'll make sure that I'll give them coffee, or I'll give them dinner. You don't have to agree with them, but at the same time, you don't have to say that there's nobody there. You can kind of try to, again, you'll have to play it by the ear and see what works for that particular situation. Often what I tend to say when they talk about that to me in the clinic is, I kind of try to validate their experience. I kind of say empathic comments like, I know that must be quite scary. I know that must be quite difficult for you. So what do you think we can do about it? So kind of just putting it back to them and asking them for suggestions, because nobody asks them that. And that often helps for them to feel a little bit empowered, because it's a very scary experience. Now imagine having that experience for yourself and putting yourself in their shoes, and kind of having to go through that can be quite scary. So putting ourselves in that situation and trying to deal with that, how would you want to be kind of heard when you're saying about these things, is a very good way of reflecting on how you'll react to them. Next slide, please. Now, I know this is not the focus of my talk, so I won't spend a lot of time here, but depression can happen in about 30 to 40% of people with Parkinson's disease. Many times it coexists with psychotic symptoms. And there are times when depressive symptoms can wax and wane in someone with Parkinson's disease. And similarly, psychotic symptoms can wax and wane. So we'll see that there is a clear association between depression, anxiety, and psychosis in Parkinson's. So that's quite important for us to pick that up and treat such symptoms when they happen. Dementia, again, quite common in Parkinson's disease as the illness progresses. There are various other types of Parkinsonian syndromes, not just Parkinson's disease. Diseases like dementia and Lewy body disease or other Parkinson plus conditions, where you may have Parkinsonian symptoms, but it's not Parkinson's disease. And in such people, you will actually find a preponderance of neuropsychiatric symptoms, and particularly dementia and cognitive impairment. Sleep problems, restlessness, restless legs, REM sleep disorder, acting out their dreams, kind of shouting in their sleep, are again common experiences in people with Parkinson's disease. Again, I will not kind of linger on these points now. So next question is, why does psychosis occur in people with Parkinson's disease? I think I'm okay for time. Yeah. So there are changes happening in our brains as we develop Parkinson's. Okay, and that's why we develop symptoms, the motor symptoms of Parkinson's disease. Similar things happen in other regions of the brain that are responsible for manifestation of the psychotic experiences. So the first thing that happens is the changes, the inherent changes of Parkinson's disease, which affect our brain, and that directly results in these experiences. That's the first reason. The second reason, next slide please, are the medicines that are used to treat Parkinson's disease. The common ones like levodopa, or previously people used to be given bromocriptine and drugs like that, but dopamine agonist drugs, or even more newer drugs which are now being used, and even drugs like Pacitane, which are commonly used in people with Parkinson's disease, they actually have a higher propensity for precipitating psychotic symptoms. And this often happens when a new drug is being introduced or when the dose of the drug is being titrated up. So the change in the level of dopamine and the changes which it subsequently does to other neurotransmitter systems within the brain are an important reason for people to develop psychotic symptoms. Next slide, please. Other co-occurring conditions, which we already talked about: infections, constipation, pain, falls, poor vision, poor hearing, all those things, poorly controlled diabetes, hypothyroidism, hyperthyroidism, whatever. So all these things can actually have a direct effect on the brain and can precipitate psychotic symptoms in someone who didn't have these symptoms before. Next slide, please. Then medicines which are used to treat these physical health problems which happen in someone with Parkinson's disease. So the simple things are asthma. When someone develops severe asthma, when they are given drugs like corticosteroids, steroids, or when someone has a heart failure, using a drug like digoxin, often can result in psychotic symptoms. So again, very important to look at what's changed recently in their history. So were they given any new drug? Did they develop any new complication? So trying to identify if those things are contributory. Next slide, please. The co-occurring psychiatric disease. So it could be that they have a longer history of psychosis even from before, and this could be precipitated during these circumstances, or it could just be a kind of a chance coexistence of psychotic symptoms. So when you look at the theories of why someone develops psychosis in Parkinson's disease, previously we used to think in a straight line. So someone develops Parkinson's, you give a drug that causes psychosis. So we had a straight line theory for causal reasons for someone with psychosis in Parkinson's. But now as we find more and more evidence, it's becoming clear that nothing is straightforward. In fact, nothing is straightforward in life, and it's kind of the same thing holds true in Parkinson's. So various things come together in a kind of a toxic cocktail, and that precipitates or makes the psychosis worse when someone develops these symptoms. It may be that they developed psychosis because of the medicine changes that were done, but even after you remove the medicine, the symptoms don't get any better. That's because there are other things which are happening in their system, which is making things worse and making things to perpetuate. Next slide, please. So why is psychotic symptoms important, other than the fact it's a common experience and it can be very distressing for people with Parkinson's disease? Caregiver distress kind of goes up, and if it goes through the roof, in fact, when someone develops psychosis. Looking after someone with Parkinson's disease, just with their motor problems, can be a challenge. And when they develop psychotic symptoms, when they don't trust this caregiver, they don't allow this caregiver to come near them, it can be quite a challenge to look after this person. And that causes a lot of distress for the caregivers. The symptoms are progressive, so they tend to get worse if they are not adequately managed right at the beginning. So it's important that you address that right at the beginning. Now, people who develop psychotic symptoms in Parkinson's disease are more likely to end up with serious problems and end up in a hospital, nursing home, or end up with dementia. And also the rate of mortality increases quite rapidly after they develop psychotic symptoms. Next slide, please. So how can we prevent psychosis from happening? Simple steps. It's not rocket science. Simple things. Looking at their environment. What can be done to make it easier for them? What are the triggers in the environment which causes them, or which makes them distressed? Can we address those things? We already talked about that a lot. Social engagement. Social isolation is a big problem. And when you kind of start engaging them socially, it actually is very helpful. Social engagement is very important, a very powerful way of dealing with psychotic symptoms. Correcting sensory impairment. So checking their glasses. When sometimes you ask, when was the last time you had an eye check? More than 10 years ago. They just don't feel the need to go and check their eyes again. So looking at whether they are developed cataract, often not addressed, and often people are a bit scary of operating on someone with psychotic symptoms because they think they will not follow through the process of getting a cataract surgery properly, or they may become violent and confused in the hospital. Yes, given all that, we need to treat that. We need to address that. Checking their hearing aids, looking at their physical health, good nutrition and hydration, and careful. Whenever we start a new drug, we do it very carefully. Starting at a low dose, start low, go slow. And if you're doing something different, we just need to make sure, again, warning, having a discussion with the patient, discussion with the family, it's extremely important. Just to warn them that this might happen. If it happens, don't panic, just stop the drug. I mean, this kind of discussion that it's worth having with families and with people who are experiencing Parkinson's. Next slide, please. So how do we treat? Treating psychosis in Parkinson's is quite tricky, can be quite tricky. The best way is to prevent it. If you can prevent it from happening, that's the best thing we can do for our patients. But when it does happen, we can treat it, but can be a little bit of a challenge. The reason being, whatever treatment that we're going to suggest, whatever management plan that we're going to suggest, it can worsen their Parkinson's symptoms if you try to reduce the drug or add a drug for psychosis, and vice versa. When you treat their psychosis, their symptoms, Parkinson's symptoms get worse. When you treat their Parkinson's motor symptoms, their neuropsych symptoms get worse. So it's getting the delicate balance right. That's why it can be a challenge sometimes. So working in close collaboration with the person with dementia, Parkinson's disease, family members and caregivers, and also in consultation with other professionals working with a person who is suffering from Parkinson's disease and psychosis. So working with the neurologists, geriatricians, and liaising with them and making sure that the dosage adjustments are happening at the right times, at the right levels. So that's a key thing. Next slide, please. So in simple steps, the first thing we tend to rule out are infections. Do they have a urinary tract infection? Is the diabetes being managed all right? Do they have any electrolyte disturbance? Things like that. Are they constipated? Do they have pain? Addressing all these things become very important. This is the first step. Next step. Next slide, please. Check if the drugs used for non-Parkinson's conditions, are they still necessary? If they may have persisted on a drug which was started when they had an infection and they just continue. And maybe it's time to stop that. So maybe you can look at all that. Next slide, please. Check if any drugs that were made for Parkinson's disease can be adjusted. Often I tend to use the logic last in, first out. So whatever drug was added last, you can probably take it out and see if the psychosis comes down. So we work on that. So the common drugs that we use for managing psychosis in Parkinson's disease are two drugs. One is quetiapine, second is clozapine. Quetiapine is a very good drug. The problem with quetiapine is that people always don't respond completely to that. And that can become a problem beyond a certain dose, because people tend to develop various problems because of the drug itself. As I said, achieving the delicate balance can sometimes be tricky. The other drug, clozapine, is excellent, can give really good results, but again, there is a slight risk of people developing lowered white cell count in their blood, so which can make them prone for infection. So we actually advise weekly blood tests. And you'll be surprised to know how many people are needle phobic. They don't want to have weekly blood tests. And that often limits the use of this drug in people with psychosis and Parkinson's. But I tend to advise that it's probably lesser evil compared to the other experience that they may be going through. Again, we start at a very low dose and slowly titrate the dose up. And usually I start at 6.25 milligrams of clozapine and to a maximum of 50. Rarely have gone up to 100 milligrams of clozapine in someone with psychosis and Parkinson's. Again, not everybody respond completely to these drugs. Often you will kind of see that the most distressing symptoms may come down to a large extent, but they still have remnants of the symptoms. And maybe it's something which we kind of have a discussion with the family, with the person with Parkinson's, and talk about, is this okay for you, or do you want to increase the drug anymore? And that's kind of, it's an ongoing discussion that we tend to have. Next slide, please. Now I'd like to finish with some simple tips for caregivers who are dealing with someone who is experiencing, even for people who are experiencing the symptoms themselves, how to deal with that. It's very important that we understand the complex nature of this problem. It's not a simple drug causing symptom. It's quite complex. There is more happening in our brains than that. Now, many caregivers find it difficult to understand why this person is seeing something which is not there. Now, I tend to use this kind of dialogue wherein I talk to them about, okay, now you are sitting in front of me, you are seeing me. How do you think you see me? Now, this is a question which many of us don't think about it. How do you think we see? Do you actually see the actual person, do you think? Sorry? Excellent, yeah, the light. It's just the light which goes in, but it's not the light which reaches our brain. There is lots of things which come in between. In fact, light just reaches the retina, and there are photoreceptors in the retina which convert this light energy to something else. Chemical energy, action potentials, electrical energy, which is then transported through various tracts through the brain to our visual cortex, which is the back of the brain. Once it reaches there, it doesn't stop. There are association areas which project these impulses which come from the retina. It all happens very quickly. So as it comes in, now how do I know this is a bottle? Because there's a pattern that is registered in my brain which says this is a bottle, I have a name for it, and I haven't seen this particular bottle before, but I know nonetheless this is a bottle. Okay, I haven't seen this particular chair before, but I know this is a chair. Okay, so we have patterns or abstract concepts of what things are in our brain. So that area gets activated, and for that to happen, attention needs to be kind of roused, and there are areas from our brainstem which project into these areas to say, you need to focus on that, you need to look at that. Okay, when there are insignificant things which are happening around us, we don't tend to pay attention to it. But when you have a kind of a hyper arousal state where your attention is at a very high level, which often happens in Parkinson's disease, at times their attention is so aroused that they tend to focus on things which may seem insignificant to you. Okay, and that results in misperception of stimulus or perceiving stimulus when nothing is there actually. Okay, that's what causes hallucinations. So it's the electrical impulses in the brain which are controlled by various pathways, various neurochemicals, all coming together to the final experience of actually seeing something which is there or which is not there. So when the stimulus, when a brain which doesn't have Parkinson's disease perceives a stimulus, a visual stimulus, it's actually a visual stimulus which is coming through the retina. For someone with Parkinson's disease and experiencing hallucinations, there need not be a stimulus coming from outside, but the brain is generating electrical impulses, which to them is as real as the person sitting next to you is right now. Okay, When somebody tells you there's nobody sitting next to you, you may start to feel annoyed. Are you joking to me? Are you kind of joking? You're playing with me? And if somebody persists, so you may become angry. And that's what a person with Parkinson's disease does. To them, it is very real. They just can't understand why you can't see what they are seeing. Okay? So it's important for us to understand that and accept that. So understanding and accepting the experience is the first step before you can do anything else when you're working with someone with Parkinson's disease and psychosis. So being alert to early warning signs. So somebody is not sleeping very well, somebody is not eating that much, somebody is looking a bit more preoccupied, somebody who is a little bit more restless. Okay, they are kind of talking a little bit which doesn't make sense to you. So you may want to be alert to these changes happening and bringing them to medical attention immediately. Okay, and getting help as early as possible is extremely important. Do not confront, do not argue with them, do not dismiss the symptoms, and do not try to disprove their experience. Okay, and that often annoys people. Okay, and that is often the result why people tend to end up with a huge problem, and there is they don't talk to each other in people's homes, and that's often happening because people don't respect or kind of validate the other person's experience. Okay, so it's extremely important that we don't do that when you're dealing with someone with Parkinson's disease. So I think that's me. So in summary, psychosis is common in Parkinson's disease, but it's eminently treatable. We can treat it. It's a challenge, but can be treated. And often it can be prevented. That's the key message that I want. If there's one message that you can take home with you, it is that psychotic symptoms in Parkinson's can be prevented, and that's the best way to deal with it. So being aware and alert and getting help as early as possible are important things that can help someone with Parkinson's disease. Thank you.